Good. Logged in.
Morning, sir.
Sorry. Good morning, Amarjit. The last month for you.
Yes, sir.
Well, all the best in Kashmir.
Thank you so much, sir.
Are you at the medical college or by private practice?
No, sir, I'll start looking for jobs after this.
Acha, you're from Kashmir originally?
Yes, sir.
Okay. Well, hello to all the others that are on also. Prakash, Jaybalan and Dharani and Abdul Kareem, Rohit.
Good morning.
And the PT clinic. All right, I'm going to mute myself.
Good morning, Rohit. Please start.
Good morning, sir. Can I start my presentation, please?
Yeah, please. Good morning.
Yes, sir. Good morning. So today I'll be talking about on the pathoanatomy and the risk factors of patella instability. It is more commonly seen in female adolescents, has a higher recurrence rate after the first dislocation. Normally, it's around 20%. If there's a dysplastic trochlea involved, then it's around 60%. After the second dislocation, yes, sir.
Yeah, I can just see the first. Title.
No, I haven't changed. I haven't changed.
Okay. Fine.
After the second dislocation, the instability rate increases to around 50%. So when we have a look at the anatomy, we come to know that this is the largest sesamoid bone in the body. It links the exterior mechanism through quadriceps tendon and the patella tendon. It is the thickest articulating cartilage in the body. That's around 7 mm. 2/3 of the patella articulates, and the distal pole does not. When you come to look at the stability factors, there are two important stability factors. One, you have the static stabilizers, and the other one is the dynamic stabilizers. Statically, you have the anterior, the lateral, and the medial components. The anterior will comprise of the patella tendon. This will limit the excursion of the patella anteriorly. Laterally, it comprises of the great muscles and the superficial and the deep retinaculum. And medially, you have the MPFL and the meniscopatellar. Dynamic stabilizers, major one is your VMO. The other vastus are also dynamic stabilizers. Along with that, you have the IT band. Before we get into the tracking, we'll also look into the trochlea. The factors that affect one of these are the trochlea groove, high and lateral trochlea, the MPFL, the high patella, and whether the patella is contained in the deep trochlea or no, or whether there's a shallow trochlea. So when you look at the tracking biomechanics, you come to know that on 30 degrees of flexion, both lateral and medial retinaculum become lax. Thus, the patella tends to move medial and laterally and starts gliding. On external rotation of the leg, the medial MPFL becomes taut and the lateral structures become lax. This starts making the patella move more laterally and ends centrally. On internal rotation, MPFL becomes lax and lateral PFL controls patella to centralize in the trochlear groove. Laterally placed tibia, the TTTG, pulls patella towards lateral side and medial PFL tenses and lateral PFL becomes lax, increasing the Q angle. Thus, patella ends laterally in the groove. The other factors for tracking pathology are the local factors and the global factors. Local factors will include your tight IT band, the taut lateral retinaculum, the lax medial structures, the trochlear dysplasia, flat trochlea, weakness of the quadriceps. Global will include excessive genu valgum, external rotation of the tibia, excessive femoral anteversion, and the fibrination component. So the major muscle that acts is the quadriceps anteriorly, superiorly, and the patellar ligament inferiorly. This results in a compressive joint force on the trochlea by the patella, dependent on the position of the knee and the tension. So this increases the area of patella and decreases femur, stress on the articular tissue. This causes high patellofemoral joint reaction forces with a small contact area, leading to higher stresses. When you look at J tracking, when you go on extending the knee, slowly the patella starts moving laterally in an inverted J fashion. You can divide the instability into grade 1, grade 2, and grade 3 components, depending on where, how much the patella translates. These are the contact areas, more commonly at a higher degree on the lateral trochlea. If non-weight bearing increases contact area, knee flexion from 0 to 90 degrees, patellofemoral stresses increase more. Open chain exercises decreases joint stresses. If foot is fixed, the patellofemoral joint reaction force increases from 90 to 45 degrees, then decreases as the knee approaches in full extension. You can see by the markings on the colored markings on the trochlea and the patellar surface. The vector forces of on the coronal view, the major muscles pull the patella laterally. There's only one muscle that pulls the patella medially. Two major structures actually that pull the patella medially and keep the patella contained in the trochlea. One is the VMO, the other one is the MPFL. Vector forces of the rectus femoris, the lateralis, and the patella tendon act on the lateral aspect. Patellofemoral joint reaction forces, this increases with every activity. For stance faces around 25 to 50% of the body weight, peaks in about 20 to 30 degrees. When you're climbing stairs, it's 2 to 3 times body weight. When you're running, it's around 5 to 6 times body weight. Flexion greater than 90 is around 8 times body weight, and squatting, the body weight pressure increases to around 20%. You can classify a patella instability as type 1, type 2, type 3, 4, and 5. Type 1 will have no instability and no maltracking. Type 2 will have instability but no maltracking. 3 will have instability and maltracking both. It has components of 3A, soft tissue contracture, 3B, patella alta, 3C, pathological TTGG. TD is genu valgum associated, and E will have a torsional deformity. Type 4 is instability and loss of tracking. Type 5 has no instability but maltracking. It can also be classified as acute, chronic, and habitual, depending on the type and the number of subluxations or dislocations. Coming to the risk factors, major risk factors are listed here, including physical activity, gender, age, anatomical and structural factors, tissue factors, groove angle, trochlear depth, central condylar height, TTTG. And also, along with this, you have anatomical factors like increased Q angle, femoral anteversion, etc. Physical activity, excessive duration of or frequency of physical activity will lead to an increase in patella instability. Errors in training, sudden movements, sudden twisting. They term this as the dynamic valgus force, where your femur is adducted and internally rotated, and your tibia is externally rotated and abducted with a slight valgus. This predisposes to patella instability or subluxations. Change of training surfaces, inappropriate footwear such as high heels. Gender Stengler and risk of 33% probability then men to get patella instability, whereas Mary and Elizabeth and again showed that they did not find any gender differences. Age was also another factor that many studies have looked into, but this interesting study showed that it happens more in 10 to 17 years when the adolescent is more into jumping, twisting, and sudden activities, and the muscles are kind of lax. Looking into the anatomical factors, here you can see the 4 major ratios. Here you have the Insall-Salvati ratio, that is nothing but the length of the patella tendon to the length of the patella. The second major one that we look into these days is the Captain-Deschamps ratio. That is nothing but distance of the lower edge of the joint surface of the patella to the anterior superior edge of the tibia. And the other ones are also there, that the modified Insall-Salvati ratio and the Blackburn ratio, which Dr. Dharani will look into. Patella alta, basically a high patella will increase the Q angle. So an alta of more than 1.5, 1.3 will increase the Q angle, thus inducing dynamic valgus and causing patella instability. This is another way to look into the high riding patella. So they look into the contact area between the two cartilages, the trochlear cartilage and the patella cartilage. If it is normally, it's around 12 to 15%. If it is less than that, then there's a high riding patella. You look at the Dijon classification for trochlea, you see type A has a crossing sign and a shallow trochlea. Type B has a spur crossing sign and a flat trochlea. C has a convex trochlea, and D has a cliff with a hypoplastic medial sign in C and D both. Here you can clearly see the crossing sign, the medial ridge, the sulcus terminale, where you can differentiate the lateral and the medial condyle. You can see the Blumensaat's line. You can also see the superior imposition of the two condyles and the patella surface. Coming to MPFL variations, this interesting study by Kevin Shear showed that 63% of the specimens that they looked into had an origin of MPFL that was distal to the physis. 31% had an original that was proximal to the physis. This information shows anatomical variation of the MPFL origin with age, with older specimens having a footprint that was more proximal and anterior than younger specimens. They also you have the insertional points, that is the anatomical insertional point that is found by the Schottle's point. When you have a posterior line, posterior cortical line coming down, the Bumensatz line and the line from the posterior condyle. So the area between these two lines is where normally the MPFL originates. Coming to generalized laxity, this is measured by taking Beighton score. You look into the little finger flexibility touching the posterior dorsal aspect, the thumb touching the radial aspect, the knees bending completely in recurvatum, elbows again recurvatum, and spine where you can touch the floor without bending your knees. Each have 1 point. And then you can differentiate if more than 5 that the person has ligament laxity, like generalized ligament laxity. Another thing is the VMO hypoplasia. Here you can see on the axial image that the vastus is normal, so the patella is centralized. When the vastus VMO is hypoplastic, the patella tends to go in a lateral direction. You can see the same on the sagittal as well as the coronal images. Increased Q angle. In Q angle is nothing but the angle formed subtended between the ASIS and the patella and the ligament patellae. Normally, this higher the Q angle, the tibial attachment, the more valgus the specimen has, thus increasing risk for patella instability. You can also see the torsional forces acting in this image. Increased femoral anteversion. Again, when you have an increased femoral anteversion, your femur tends to go into a state of adduction and internal rotation. Thus, the tibia tends to compensate by going into more external rotation and abduction, increasing the Q angle, which then will lead to a patella instability. So a normal Q angle less than 15 degrees is okay, but a Q angle more than 20 degrees predisposes to patellar subluxations. This is the dynamic valgus I was talking about before, where you have your femoral adduction, internal rotation, the tibial external rotation, and the tibial abduction, leading to a dynamic stress on the knee, which tends to form subluxations and dislocations of the patella. This is the external rotation, where your patella tends to have a lateral force that is pulled by the vastus, the lateral structures, and your insertion of the tibial tuberosity and the patella ligament. The other interesting thing that these parameters look into is the increased groove, the increased sulcus angle, the increased TTTG, where you can see clearly that if a sulcus angle of more than 140 degrees will show that there's a shallow sulcus, thus predisposing to patella instability. When there's a trochlear depth of less than 3 mm, again, that denotes a shallow sulcus, which predisposes to patella instability. A TTTG more than 20 will predispose to lateral insertion of the tibial tuberosity, leading to an increased higher Q angle, leading to subluxations and dislocations of the patella. This will be covered in depth by Dr. Dharani. Thank you.
Yeah, Rohit, pathoanatomy wise, you had
Yes, sir.
paper on natural history update.
Yes, sir.
Can you elaborate what was that paper on?
So which one, sir? Which paper?
Natural history of dislocation.
Yes, sir. 1 second.
Go back.
Yes.
No, the next slide. No, next one.
This one, sir, natural history.
Yeah, yeah.
So,
Adolescence.
sir, nothing. So they were just basically talking on the adolescents having lax tissues because their muscles are not yet taut. Firstly, secondly, they have a propensity of active sports, active jumping. Sudden, their bones are softer, so they tend to push their joints to a more limit than what adults do. And this is the reason why around 10 to 17 years of age, when there's a growing region, it tends to subluxate more because the exact angles are yet to be formed in the body.
Okay. So other thing which I found is one is
Yes.
this adolescence, and female, definitely female has a higher incidence. That's what I would say. Gender, you said not much of difference. One of the papers quoted, but in
Right.
our practice, we noticed female definitely has higher incidence, and especially in the age group where they become during pregnancy and postpartum. Probably the reasons I would say is during pregnancy, I mean, they do have ligament laxity because of the hormonal changes, and they
Okay.
gain their weight. And post pregnancy is a time when they start squatting and the activity level goes up, and chance of sitting and turning activities in the bed when feeding, all those are the factors which actually has a chances of fertile instability during that phase.
Right, sir.
So I do warn all those adolescent kids or who are in their 20s that this has a higher chance during pregnancy or after childbirth, which will be transitional. So they have to do the exercises during that phase so that they're mentally prepared. So when they go through this again, they'll be really scared. During pregnancy, they will not come for consultation, but they'll be really scared and the mobility will reduce. So by
Right, sir.
warning them, you can actually reassure them that this might come, but because during that time, if you advise surgery, it's not possible for them to undergo surgery for an instability. So we can always tell them after pregnancy, you come back. After 6 months of delivery, you can come back for surgery. But
Right.
usually this resolves, which is during pregnancy, when they reduce their weight again later. So that's another part which I think which I've
So,
noticed, which
so
is
I
probably
guess
not. Sorry.
I guess what must be happening is that the weight and the hormonal changes must be putting the knee into a dynamic valgus constantly.
Is there any paper, I mean, describing that during
No, so
pregnancy,
I didn't
postpartum?
find it. I didn't find any.
So that's an opportunity for us to write a paper on that. So you
Yes,
can
sir.
work on it.
Right, sir.
You can see the series. And the only thing which we have to do is collect the cases which come to the OP. Fertile instability OP, I mean, during pregnancy or postpartum.
Yes, sir.
How to write it, we will see. Nothing much to
Santosh,
add.
I wanted to add something.
Sir.
You know, in pregnancy, there is a formation of relaxant, which really relaxes the pelvic musculature, and at the same time, the pelvis widens, results
Yes.
in more adduction of the femur, and consequently, valgus of the tibia or walking. And I think relaxant plays a part in the muscle relaxation, especially if the patient has a TT or a high Q angle. That's what I think.
Yeah, definitely, sir. I mean, that is been described and explained for pelvis, but I'm not sure whether it's related to petla instability. If it's not been reported, probably we can report it and tell that as in a paper form. But how to write it as a paper with evidence is what we need to see. So. Sir, anything to add, sir?
No, nothing different. Thank you.
So Dharani
Thank
Kumar,
I'll
thanks a
stop
lot.
sharing my slide. Yes, sir.
Yes, sir. Am I audible, sir?
Yeah, Dharani, please go on.
So coming to clinical and radiological evaluation of patellofemoral instability. So just a minute. Got hang adjustment. Hello, sir. Am I audible, sir?
Yeah,
Sir, am I
Dharani.
audible? Sorry, it got hanged actually. Coming to the normal patellofemoral stabilizers, static stabilizers are by trochlear geometry, patellar height, including patellar tendon, femoral axis if increase the femoral anteversion or increase the tibial torsion. Dynamic stabilizers are by quadriceps tendon and muscles. Passive by medial patellofemoral ligament medially and lateral retinaculum laterally. Functional stabilizers are by hip abductors, hip external rotators, or hyperpronation of the foot. Patellofemoral stability is mainly based on soft tissue and bony morphology. Soft tissue comes into place between 0 to 30 degrees. That is mainly from 20 to 30 degree, medial patellofemoral ligament takes part. More than 30 degree, patella comes in contact with trochlea and gets engaged. So pathoanatomy is complex and multifactorial in origin and varies individually. Some important factors are patellar abnormality in terms of shape and size, trochlear dysplasia, malrotation in case of increased anteversion, genu valgum, and increased lateralization of the tibial tubercle. So important principle that to be known in patellofemoral instability is that the factors may be individual or a combination of different factors such as muscle force, insufficient articular congruency, limb alignment, or direct trauma. Proximal hip muscle control is important in maintaining the trochlea under the patella. And hyperpronation of the foot can also contribute to increasing the patellar instability. And also in dynamic, when patient is mobilizing, weight-bearing muscle contraction compresses the patella into the cavity of the trochlea, thereby improving the stability between the patella. So DiGiorno in 1998 found out there are 4 principal risk factors for patellar instability. That is trochlear dysplasia in 96%, increased TT distance of more than 20 mm in 56%, increased patellar tilt of more than 20 degree in 83%, or increased patellar height, that is more than 1.2 ratio. So the factors contributing to the instability are patholaxity, that is either too tight or too lax of the medial or lateral patellar soft tissue constraint, decreased constraint in case of abnormal shape of patella or trochlea, and also in case of increased patellar height. On other global factors such as abnormal skeletal alignment, that is increased femoral anteversion, increased tibial torsion, or foot hyperpronation or genu valgum can also constitute to decrease in stability of patellar femoral joint. In case of a deficient proximal muscular strength, results in abnormal lower extremity kinematics. So most common pattern of acute patellar dislocation is in case of strong quadriceps contraction in flexed and valgized knee. It pushes the dislocates the patella outwards, and also in case of internally rotated femur on externally rotated tibia, puts pressure on patella and can also dislocate. So there are many papers suggesting the reason for failures in patellofemoral stabilization, and it was found that the reason behind is incorrect assessment of concomitant risk factors for stability, and also improper selection of patient, and also technical error. So the proper clinical evaluation is a key to success. So let's see clinical evaluation. It goes by listen, look, and examination. Coming to the history, for the initial injury, we have to ask for history of injury, such as whether it is a low energy or high energy, and swelling the time of initial injury, whether it is associated with osteochondral fractures or not. Description of pain at the time of injury, and the history of dislocation, whether it got reduced spontaneously or need any manipulation, and also family history to know about the systemic hypermobility. In case of recurrent injury, we have to ask for whether pain is for severe and swelling this time of injury. And also we should ask for the age of onset, because if the age of initial onset of dislocation is less than 14 years, then the chances for further instability increases by 60%. And also we should ask for the number of episodes of instability, which also increases the rate of recurrence. Pain and instability, more of a problem. We have to ask for the patient which one is disabling him the more, and also ask for the duration of the disease. And we have to ask for the aggravating factors, whether it is dislocating habitually or any particular movements, and also relieving factors to be noted down. And because recurrent injury, this patellar dislocation is more common in younger age group, that is 10 to 19 years, which constitute about 70%. And if after first dislocation, the patella tends to dislocate up to 48 to 50%. That is, half of the patients who went on first dislocation can again recur with the dislocation. Again, after second dislocation, it can again the recurrence rate increases. So clinical fractures mainly is based on pain, giving away sensation or popping up sensation, and also swelling, stiffness, and pseudo-locking. So coming to the examination, standing from the front view, we have to look for the mal element, that is genu valgum or genu varum. Then for the femoral anteversion or tibial torsion. Then we have to look for the shape, position, and size of the patella, whether it is squinting or facing laterally. And we have to look from the sidewards. We have to look for the patella alta, that is camel sign can be seen, that is due to the hypertrophy of the infrapatellar fat pad, the two hum can be seen in the patella. We should look for the genu recurvatum and also loss of longitudinal arches in the foot. On observation from sitting, we have to look for the patella position, whether it is facing forward or laterally. In case of patella alta, the patella is more aligned with the anterior surface of the femur. And also, we should, if the patellas, both the patellas are looking laterally, grasshopper sign eye appearance can also be seen. So looking at from posterior, we should look for a pelvis tilt, gluteus muscle contour, and femoral anteversion, and foot abnormality and gastric muscle bulk to be visualized. And also genu valgus can be seen from the posterior part also. We have to look for any hyperlaxity or patholaxity. Baton score to be calculated. More than 4 out of 9 is considered hyperlax. Local observation, we have to look for the wasting of the quadriceps, ecchymosis, swelling, or previous surgical scars. On palpation, we have to look for the tenderness of the lateral retinacular region. It should be warm, cold, or edema. And also, we should check for the IT band tightness, hamstring tightness, and gastrocnemius soleus tightness. Gait pattern, we have to look for either in-toeing gait or out-toeing gait. Because the evidence of foot pronation or persistent heel valgus, which constitute to fixed hind foot deformity or Achilles tendon contracture, can also give rise to patellar instability. We also look for the leg length discrepancies. Patellar tilt, here we compare the height of the medial and lateral patellar border at 20 degrees of flexion. Here, patella is tilted laterally, thereby elevating the lateral border and compressing the medial border. We should, if the lateral border cannot be raised, then it shows that there is tight lateral retinaculum. Basic sign, there is a tenderness on palpation on the distal pole or medial epicondyle. The tenderness on palpation may indicate the rupture or disruption of the MPFL, contributing to the reduced medial stability of the patella. It is also a pathognomonic of patellar tendinosis. J sign, here patellar tracking is seen while knee in flexion and extension. From a patient is asked to extend from flexion. If there is abrupt lateral deviation of the patella during the terminal knee extension, then it is J sign is positive. It can be due to the vastus medialis obliquus deficiency or patellar alta or trochlear dysplasia. So to check for the vastus medialis obliquus capability, we should keep a bolster under the knee at around 30 degree of knee flexion and look for the concavity of the medial aspect of the distal thigh when the patient is asked to extend against the gravity. The VMO may exhibit atrophy or hypertrophy in patellar instability and a reduction in dynamic medial stability is seen. Patellar glide test. 4 patterns are made in the patella. If the patella is moved medially and laterally, if the patella is able to move within the 2 quadrants, then it is normal. If the displacement is more than 3 quadrants, then it suggests patellar hypermobility. It shows that there is medial restraint. Patellar apprehension test, knee is flexed to 30 degree. Here the patella is pushed laterally as possible. If the patient elicits pain or apprehend ourselves to perform the surgery, then the test is positive. Gravity subluxation test, here the patient is made in lateral decubitus position and with the affected leg superiorly and knee in full extension. Patient is asked to abduct the lower limb and also contract his quadriceps. With the patient, if the patella remains medially subluxed on contraction of the quadriceps, then it is complete dissociation of the vastus lateralis. If the patella relocates laterally, then the patellar vastus lateralis is intact. It shows that there is an overzealous correction of the lateral release surgery. Coming to Clark test, here knee is in slight flexion, and here examiner is pressing the patella in the superior border, then ask the patient to contract his quadriceps muscles. If the pain is elicited, then the test is positive. Coming to Q angle, patient is asked to stand in or supine position with the knee extended. Line is drawn from ASIS to the center of patella, and another line drawn from the center of patella to the tibial tuberosity. And the angle between the 2 lines are Q angle. In male, it is 10 to 12 degree. In female, it is 15 to 18 degree. Coming to tubercle sulcus angle, line from the center of patella to the tibial tubercle and line through the femoral condyle. Usually, the angle between 2 is 0. If the angle is more than 10 degree, then it shows that there is lateralization of the tibial tubercle. We also include other examination like passive and active range of movements of hip, knee, and ankle. We have to look for any pathology in hip, such as FAI, or we have to look for the femoral anteversion by performing Craig test, and also tibial torsion by performing thigh foot angle. An assessment of patellofemoral instability includes we have to look for hyperlaxity in patient, and also in limb we have to look for the rotational and axial deformity. In soft tissue we have to look for integrity of the medial patellofemoral ligament. In patella we have to look for the position, height, tilt, and translation. And range of movements we have to look for the J sign. So coming to the goals of imaging, diagnosing it helps in diagnosing the patellofemoral instability and to evaluate other injuries and also to predict the likelihood of the recurrence. It also helps in the planning for the surgery. So the aim of imaging is that we have to know why the dislocation has occurred and which structures are damaged. Coming to the X-rays, X-rays are being the most available and relatively low-cost modality. It is used in image for assessing the patellofemoral instability. The 3 standard views are taken. That is AP view with knee extended, lateral view with knee flexed at 30 degree, which describes about patellar height and trochlear dysplasia, and also merchant view at 30 degree of knee flexion. So X-rays gives an assessment of patellar alignment, patellar height, and bony abnormality. On AP view, we can assess the congruence of the patella within the trochlear groove, and a lateralized or tilted patella may indicate lateral patellar instability. It also gives signs of patellar subluxation or dislocation. In the lateral view, patellar height can be assessed. One of the methods is the insult-cavity ratio. Here, the distance from the inferior pole of the patella to the tibial tubercle, and the ratio between the 2 distances considered. In case of modified insult-cavity ratio, only the articular surface of the patella is included. The ratio is more than 1.2, it suggests patellar alta, thereby increasing the risk of patellar instability. Coming to Caton distance index, the distance from the inferior articular point of the patella to the tibial patu and the length of the articular patella. So the ratio between 2 if it is greater than 1.3, it suggests patellar alta, thereby increasing risk factor for patellar instability. It is the most reliable one because it is not altered in distalization of the tibial tubercle surgery. It is the ratio of length measured from the inferior articular patella to the point perpendicular to the tibial plateau, and also to the length of the articular surface of the patella. It also assesses the patellar height, and then if index is increased, it suggests that it is a patellar alta, and thereby increasing the potential of instability. So on lateral view, we can also assess the trochlear dysplasia. So you can see the blue line is the central trochlea, that is trochlear groove, and the red line depicts the anterior border of the femoral condyle of both medial and lateral. So Rajor in 1998 classified the trochlear dysplasia. In type A, we can see the crossing sign because the trochlear groove is shallow. We can see only crossing sign alone. And in type B, the trochlear groove is shallow and also depth progressively shallower from proximal to distal. Here, the only sign we can see is that supratrochlear spur. Here in type C, because of the medial hypoplasia, medial condyle hypoplasia, and also deep trochlear groove, a double contour sign is seen. In type D, because of the more shallow trochlear groove and medial condyle hypoplasia, we can see double contour sign along with supratrochlear spur. So in Merchant view, we can calculate the sulcus angle. It is a line formed between the two lines joining the highest bony points of medial and lateral condyle to the lowest point in the intercondyle notch. So higher the sulcus angle, the trochlear dysplasia increases, and also thereby increasing the chance of patellar instability. Lateral patellofemoral angle is an angle formed between line across the anterior point of the femoral condyle along the articular surface of the lateral patellar facet. So normal patellofemoral angle is opens up laterally on normal knees. If the line is parallel or becomes converging, then it shows that abnormal patellar tilt, and it can chances of subluxations increase. It is a measure of patellar laterization or subluxation. Confluence angle is measured by bisection of the sulcus angle and the line through the posterior point of the patella to the intersection. If the lateral deviation of the patella is more than 16 degrees, then it is considered abnormal. And in CT images, the congruence angle should be 0. If it is more than 0 or abnormal 0, then it is abnormal. Coming to patellofemoral index is the ratio of the medial and lateral patellofemoral joint spaces at 20 degrees of flexion. So if there is relatively widening medially, it's an indication of lateral patellar tilt. So value greater than 1.6 is considered abnormal. So the risk factors for patellofemoral instability are considered to be trochlear dysplasia, patellar height, patellar lateralization, patellar tilt, and tibial tubercle lateralization. Patellar height is a significant factor and considered to be one of the most reliable indices. Tibial tubercle lateralization, that is TTDG, is widely used and considered to be a reliable method. Coming to CT evaluation, most of the patellar maltracking occurs between full extension and 30 degrees of flexion, so that the subluxed patella moves into the deeper portion of the trochlear groove. So CT evaluation is an idea about trochlear morphology, tibiofemoral rotational profile, patellar height, articular injury, and associated injuries. So how to calculate TTDG index? This is an imaging method to measure the Q angle. Here, the distance between the anterior tibial tuberosity and the trochlear groove, and it gives an assessment about the anatomic relationship between the tibial tubercle lateralization. It starts from femorotibial articulation down to the level of the anterior tibial tubercle and insertion of the patellar tendon. Both images are superimposed and the distance between two is measured. If the value is more than 9 mm, then it shows that there is patellofemoral malalignment. If the distance is more than 20 mm, then it gives an indication for surgery. Patellar tilt angle is an angle between the two lines, one along the posterior condyle of the femur and along the lateral patellar facet. Normally, it is less than 8 degrees. If it is abnormal, then it shows that tight lateral structures, deficient medial structures, and malposition of extensor mechanism. Trochlear inclination is an angle between the posterior condyle of the femur and along the lateral trochlear facet. Normally it is more than 11 degree. If it is less, then it shows that it is a trochlear dysplasia. It is the depth of the trochlear groove. It is best measured at 3 centimeters above the tibial plateau or at the femoral physeal car. Normally it is around 3 to 5 millimeter. Lateral patellar shift measurement is the distance between the vertical line drawn through the center of patella and the vertical line crossing through the center of the femoral trochlear surface. It measures the lateral translation of the patella in relation to the femoral trochlear groove. The increased lateral shift indicates that is lateral patellar instability. CT evaluation can also be used in assessing the femoral axis, that is femoral anteversion angle. The line joining along the femoral neck and the coronal line joining the posterior femoral condyle. Both images are superimposed and the angle between the two lines are calculated. If it is more than 25, then it is considered to be abnormal. The values that are measured in radiographs can also be confirmed with CT evaluation, like lateral patellofemoral angle, subcus angle, and congruence angle. So MRI evaluation, it is considered to be gold standard for soft tissue evaluation and provides an excellent visualization of the patellar ligaments, cartilage, and soft tissue structures. It gives an idea about MPFL, osteochondral fragment, cartilage. From this we can calculate TTG distance and also trochlear dysplasia. It is helpful in detecting the transient patellar dislocation. That is, it is highly sensitive. The indirect signs of transient patellar dislocations are hemoarthrosis. MPFL fibers are disrupted and bony bruise over the medial patellar facet or lateral femoral condyle. So hemoarthrosis is the most common MRI finding after transient patellar dislocation. Suppose here the inferior-medial patella striking against the anterolateral aspect of the lateral femoral condyle during dislocation brings about the bone marrow edema and the lateral femoral condyle or inferior aspect of the medial patellar facet. Here, the MPFL fibers can be stretched or sprained and will be seen as a wavy appearance with a surrounding edema if the MPFL fibers are intact. If it is torn or complete, it is appear as a complete disruption of the fibers with extensive surrounding edema. It can also avulse from the femoral attachment or patellar attachment. Osteochondral injuries. The inferior aspect of the medial patellar facet or anterior aspect of the femoral condyle can cause osteochondral fragments. And in acute dislocation, around 25 to 40% are positive. And also, in case of shear injuries of infrapatellar fat pad, sign positive in traumatic patellar dislocation. Other parameters that can be calculated are the trochlear facetal ratio. If it is less than 40%, it is considered as dysplasia. And lateral trochlear inclination angle, if it is less than 12 degree, then it is considered to be trochlear dysplasia. So MRI evaluation of MPFL injuries are the medial soft tissue restraints of the patella, that is medial patellofemoral ligament. The types of MPFL injuries can be ranging from the mild sprain to the complete disruption or avulsion, which can be taken up by MRI. It differentiates between the stretched or sprained or torn avulsed MPFL based on the location and appearance. So these are the examples for bony avulsion from patella. It can be seen in the upper images, and down images shows the avulsion from the femoral attachment. So a cartilage assessment can also be done with an MRI. Stage 1, we can see softening and swelling of the cartilage. Stage 2, will be fragmentation and fissuring less than 1.3 millimeter in the patellar cartilage. In stage 3, the fissuring is more than 1.3 millimeter. In stage 4, the cartilage loss will be up to subchondral. So take more images. The clinical assessment of risk factors and correct patient selection is must in assessing the patellofemoral instability. The imaging modalities predicts the risk factors for patellofemoral instability. Trochlear dysplasia, increased TTTG distance, patellar tilt, patellar alta of more than 1.2 is the potential risk factors for patellar instability. Thank you.
Yeah, then thanks. Good elaboration of all the. Are you aware of what is done in Ortho 1? The CT evaluation.
Sir, sorry, sir.
Okay, there is a special sequence of CT which is done specific for Petla instability,
Sir.
which is for tracking, dynamic tracking CT, which is cut sections of the distal femur in various angles of flexion, so that we
Okay,
know
sir.
how exactly the patella tracks
Okay.
over the trochlea, which will give us a better dynamic
Yes, sir.
idea. But strictly speaking, it is not fully dynamic, but
Okay.
at least in various angles of flexion, we will be aware what's happening.
Okay.
So to get a better idea of the dynamics, our clinical examination will help. There are so many clinical tests and
Yes, sir.
radiological views which are, I mean, will be repetition and not really useful in all situations.
Okay, sir.
So whatever we need to see whether the passive tracking is how is it, the J sign will give us an idea, and the dynamic
Yes,
tracking with the contraction of quads and without contraction of quads, we notice some difference. If
yes,
the
sir.
muscles are strong, it might not track laterally, which is good enough actually. But if the muscles are relaxed, it
Okay.
might track
Yes, sir.
laterally.
Yes, sir.
And at the same time, when the knee is flexed in supine with hip flexion, the quads will be working differently. At the same time, when the knee is flexed with hip in extension, that means you need to get the knee off the table.
Yes, sir.
So that in that position, it will behave differently. I'm not sure what is the exact mechanism, but when we take it out of the table and flex the knee further with the hip in full extension, you can actually elicit instability or apprehension better. In patients who do not show apprehension, when you go on and test it in this position, you might notice apprehension. Apprehension, by definition, I mean, it's just not pain. Any discomfort or fear is also apprehension. But at the
Yes, sir.
same time, if you give a posterior retrobatellar force, any patellofemoral changes or chondromalacia will elicit pain. So we should not think that as apprehension. So your examination must be really gentle. In acute situations, there might be a lot of tenderness there. All these aspects are gentle examination with sort of distraction of the patient. It's something like doing a pivot shift. This is regarding clinical exam. A patellar tilt is another good test where it's not related to instability specifically. It's more related to patellofemoral pain and patellofemoral arthritis. And investigations, as I said, the CT will give us a lot of information. Not only the patellar tracking, we can assess the hip anteversion and tibial torsion. Rotational profile, clinically we can check, but
Yes, sir.
confirmation of those clinical examination is
Yes,
with these CT cut sections. And you had told about Deja's.
Okay.
You didn't tell, no?
Displacement.
Okay. Deja types are there, right?
Yes,
How do
sir.
you
Total
assess
dysplasia.
how do you assess that? How do you come to that classification? Based on
Based on the lateral view in X-ray, sir,
and CT.
and CT, yes, sir.
So it's based on both. But it is a controversial classification where you might not be able to differentiate everything. So, I mean, what's the importance of Deja types? What would you see in an X-ray and for classifying as?
Sir, like more than 3 and 4 dysplasia, surgery will be indicated, sir. The sulcus angle will be more, and also there will be medial femoral condyle hypoplasia will be there, sir. The trochlear groove will be more shallower.
B and D are the indications for trochleoplasty.
Yes, sir.
C is more of hypoplasia. So if at all required, you have to elevate that. So it is like all of the I'm not going into details of trochleoplasty because any of the trochleoplasty procedure is a complex and morbid procedure. So we do not do it as an index procedure. We always do it as, I mean, we have done it, but with a lot of post-op crepitus and patients are okay, but a lot of post-op changes and chances of arthritis is high, especially in young patients. So we have reserved that only as a revisions, only in revision situation where they come with recurrence. So currently we advocate majority of cases only MPFL reconstructions, unless TTTG is grossly abnormal. So TTTG above 30 is the what we definitely do it. Anything above 25 we wait and see. And again, rotational profile malalignment. If it is in valgus, if you're doing a DFO, distal femoral osteotomy, we add a rotational correction. So those are the, investigations. All of this has a value, but all of that which you told might not be required. Only the key measurements can be done. But CT is mandatory, not a regular CT. A special sequence CT would be mandatory. Sir, your point, sir.
Yeah, but nowadays, thank you. Nowadays, in the MRI itself, Dr. Murugan and so many other MRI, they give CT, TTTG angle. How reliable are they? Are they quite different? Because we've seen some TTTG from other places, and they're giving a very low or very high TTTG. Is it possible to standardize so that we can skip the dynamic CT, or dynamic CT is absolutely essential because you know the femoral antiversion as well?
Yes, sir. TTTG by MRI measurement is different from CT, and actually MRI TTTG is better because they measure in the cartilage. Bone and cartilage, there might be variations because of thick cartilage in the trochlea and patella. So the thickness of the cartilage actually can correct the bony deformity to some extent. So MRI wise TTTG is better, but the values are slightly different. But it's in terms of millimeters, 2 to 3 mm of difference. So it is not grossly abnormal. But we do require CT for the dynamic tracking views and for other reasons, as you said, sir. So we cannot do away with the CT. So MRI, we can note the values of TTTG, but we need CT, sir, for complete evaluation.
Thank you, thank you. Well, both
And
the talks are well
and the CT helps us in actually the dynamic tracking. If you show the images to the patient, how much it is moving out, it's actually easier to convince the patient for anything. And if both sides are unequal, it's easy to convince them. When both sides are abnormal, you can still tell them that the other side also has the same chance, so we have to do rehab. And so convincing the patient is actually easy with that dynamic CTs. Thank you.
That's a very good point. And both talks are well prepared and well delivered. And so does it mean that there's no indication for X-ray at all? Because I've been always taking routinely X-ray, a lateral view, and insist on true lateral view so that you know the trochlear depth. And also in 30-degree flexion, you can calculate the insult salvati or whatever angle you want to do it. So can we do away with X-ray?
Again, as you said, sir, the CD ratio and this crossing sign and all is a X-ray description. So it is required, sir. Because CT, we do that special sequence. We do all of that as axial cuts. So we will not have idea of what CD ratio or crossing sign. So both are required, sir.
Thank you.
Physio talk, you can share your slides. Any doubts from fellows, please?
Fellows, can I ask a question? Praveen, why do we not operate on one-time dislocation when it is not type D or B? Why do we not operate on one-time dislocation? Or maybe Amar?
They recover well with the good physio, sir.
Now, in a one-time dislocation of the shoulder, age below 20 or 18, what is the recurrence chance? It's almost 90%, isn't it? That's why when they come with a single time, one-time dislocation, a young patient, we tell them you have a Bachar lesion, you need surgery. Here, what percentage? I think the Dharani's paper or the talk is that very clear. Only 50%.
Yes, sir.
50% of the time is not necessary. Am I right, Santosh?
Yeah, I'm not sure of the percentage. Dharani?
48
yeah.
to 50, 48 to 50%, sir.
Okay.
In after first time dislocations.
Yeah, that's a basis on which we treat single time dislocation patients conservatively. Right, thank you.
But David, I think we should warn them if there's, especially when they have ligament laxity, that this 50% chance would occur rather soon than later, compared to the normal patient who dislocates the patella.
Yeah, correct, Gopal. I agree with you.
There is a scoring system, instability severity score, ISS, which actually has a score where you score them, and in a first time dislocator, if the score is above 6, I guess you are actually, there is an indication for surgery. It has this hyperlaxity, age, and trochlea. I'm not sure. There is one scoring system which actually gives an indication for surgery in a first time dislocator. That is a useful tool to have. So Ganesan.
Good morning, all. Today my talk is on patellar instability, the conservative management and the post-surgical management. So the goal of treatment will be initially to manage the pain and the rest and immobilization period, and restore the quadriceps recruitment and the range of motion post the rest or immobilization period. And the apprehension and kinesiophobia is one of the key factors when we start mobilizing the patient, how to overcome them, then getting them back into functional activity and back to sports. So some of the assessments, we use the pain score, flexibility using goniometer, then the patellar alignment and other things what was talked earlier on the talks, proprioception and the strength using the isokinetic, and what we use is the iso shift, and motor functions using some of the tests, the scar exclusion test, the Kujala score, the kinetic stability, single leg hop test, step down test, and then some of the questionnaires of quality of life. So managing pain, there are some studies which says kinesiotaping can help in the managing the pain and not on the realignment. But there are studies which are done on the rigid tape, where they said there is some amount of change in the pain and not significant change in the contact area. So this is the method of taping using a rigid tape in the middle, and the pink one is the kinesiology tape, and using a step down test to see how it responds to the patellofemoral pain. And some of the measurements as discussed in the earlier talk. And this is a meta-analysis review where using various types of tapes for patellar pain. So the only thing they concluded is that, it can help in facilitating pain in some of the patients. So taping broadly is going to be athletic rigid tape and the elastic tapes, kinesiology and dynamic. McConnell tape is more commonly used and in the literature also, where there is going to be a glide where they're going to alter the position of the petla and sustain it with the help of the tape. Whereas the kinesiology taping will be an elastic one, which will also add proprioceptive feedback to the patient and facilitate the muscle contraction. So the pain during the initial range of motion, whether it is open kinematic or closed kinematic, every patient gives a different presentation and the kind of trauma they had undergone, and from that. And again, to understand whether it is a first time dislocator or someone who's had repeated trauma and then going on. Commonly, we find many of them are into some form of regular exercises, or they are on into dance, and their onset has been sudden with some twisting activity. And it is important to note for foot to see whether any pronation and tibial rotation is available on their closed kinematic chain position. So this is the isometric contraction of a quadriceps muscle. And we can see in this particular patient who had a bilateral MPFL done 10 years back, the lateral structures are overfiring, and you can see clearly the patella tracking more laterally. And I'm checking this patient both in supine and as well as in the standing position. And to help facilitate the participation of the VMO in active knee extension, we can see I'm using a muscle stimulator in the open kinematic and closed kinematic. So we will try to engage the patient to know whether he's actually able to feel the contraction. And this will be the initial progression of the exercises to go into a squats and to add the adductors component during the open kinematic exercises, so that there is equal amount of opportunity for the VMO to participate during a dynamic knee movement. Hip strengthening is one of the integral part of any lower limb rehab, and for the patients with patellofemoral, hip strengthening can be started straight away, even at the period when they are into immobilization. So we can modify the exercises and go about them. So challenges in the exercises is trying to get the quadriceps activated, which is our primary goal. And quite a number of patients initially have quadriceps inhibition post patellar dislocation. And if any of the lateral structures are tight, then we can allow it to be stretched or released. So stretching might not be possible initially, but a release using a foam roller, dry needling, soft tissue release, and selection of open kinematic or closed kinetic chain exercises will be again challenging to see which the patient has got less apprehension is able to do. Pain management can be also done by ice and TENS, which can inhibit and control the pain to some extent. Arthrogenic muscle inhibition is commonly seen in patellar dislocators, and they pose a various big challenge in initially overcoming the barrier of getting the quadriceps activated in both the conservative and as well as in the post-surgical management. So how do we go about is using the quadriceps activation battery. So this is a simple method where we are looking at three components. One is visibly the patient should be able to isometrically contract the quadriceps. Patient should be able to do a straight leg raise, and patient should be able to do a quadriceps extension without lag. So these are an indication that the quadriceps is functioning efficiently. So all the three can be present, or one or two will be present. And the activation of the quadriceps by due to the arthroscopic inhibition can also be restored using a cryotherapy. Here we saw that we are using a cryotherapy machine to get it. Muscle stimulation is also one that has been recommended to help overcome the inhibition. We can use a Faraday current, and based on how the patient appreciates the current, we can change the frequency and the duration. And this is using TENS, where it will generally try to inhibit the pain and allow the quadriceps to recruit. So the comprehensive review for the arthrogenic muscle inhibition is cryotherapy and physical therapy should be the mainstay of the management. And exercise should include traditional quadriceps hamstring muscle open chain exercises. And the progression to resistance should be gradually go on. And the evidence for neuromuscular electrical stimulation and TENS are very low, and ultrasound has got no support in this. And taping, bracing and application, soft tissue release, and they have shown some benefit. So coming on to the patella instability, the treatment is planned and informed. So the difficulty with quadriceps is there are various ways how quadriceps are activated. Some people tell the patient to press the knee. Some ask them to, pull the kneecap. But the visual feedback will help the patient where they can appreciate the contraction of the good leg, and they can also use their hand to touch and feel using proprioception. And we will check most of the patients not to use their hip muscles as a trick movements to get the contraction done. And chronic patients we see can have the component of muscle wasting. Here you can see the quadriceps wasting, how it can visibly show. And in the video down, you can see that when there is a contraction, there is more participation of the quadriceps coming from the lateral and the middle rather than the medial part. And this is quadriceps function to check in a standing position, where you can see this patient is not able to sustain and maintain a neutral position, whether that tends to go forward. And if there is a quadriceps lag, that will affect the patient's ability to walk and transmit the weight during a full weight stance phase, where they will tend to go into an extension lag. And sometimes the patient's joint proprioception is so poor that they are not even aware that there is a slight lag happening in their knee. So we put them in front of the mirror and show them that what is a straight leg from his good leg, and then educate him onto the affected leg. Now, this is a common exercise we give for patients for hip abductor strengthening, and you can see how there is a rotation component. So this is a compensation patient trying to do using the lateral structures. So this patient now will be using a lot of the vastus lateralis and the IT band to try and do his hip abduction. So that is an indication where we can pick that his lateral structures are overfiring and going to be tight in spite of the hip abductors being very weak. And this is the lateral structures compensating for a foot instability. So you can see that it tends to drop down, and the lateral structures try to tighten up and compensate to bring in that stability. So these are signs we need to pick up when we are doing their exercise program. So the role of braces can be broadly classified into the prophylactic braces, functional braces, and rehabilitative. So the studies have shown only a mixed effectiveness. The prophylactic are basically used to prevent injury, and the functional ones are to provide some stability, and they can be custom fit, and they can help in certain cases in specifically what we want them to be done. So coming on to some of the exercises which is commonly used for the patellar instability or patellofemoral pain. So it is the close kinematic chain of a leg press which is done. So the study says that the quadriceps contraction has got not much influence on the lateral patellar tilt and displacement in patients who have used the leg press, again with the position of the foot where it is kept, and the VMO targeted specifically. There are positions where they say you have to have a slightly rotated position. So studies have said that they do not give additional benefit in working with them. So this is again on a study on the knee joint position and the patellar tracking in lateral patellar compression. So it is to see in the open chain strengthening exercises, which appear to be more appropriate for the joints knee range below 30 degree. So if you're looking at patients to improve strength, and this is again commonly seen with patients with pain at that 20 to 30 degree angle. So we try and work only at the angle below 30 degree. So these are some other ways of getting the close kinematic chain exercises. So the right one is using a resistance band. So this is more functional, where we get them into a full weight bearing and the quadriceps activation. Squats, again, we go with supported squats, and mostly it is done only when there is no pain and he has better control. And there are variations of going into a single leg squat, incline squat. And this patient, you can see that the right leg trembles a lot because the quadriceps participation is less. So there's not enough strength. And after 1 month of rehab, he is now able to have better control. So the open kinematic exercise for quadriceps is one of the best exercise to improve the strength of the quadriceps, whereas the squats will be less load on the quadriceps, but the strength gain will be also very less in a squat. So we have to make sure that we go on to an open kinematic based strengthening as early as possible when there is minimum pain and muscle recruitment is allowing us. So these are some of the variations we do. We can see up in the leg curl machine, we do a short lever and long lever by changing the position of the foot supporter going up. So it changes the momentum arm and it has less load on the patellofemoral joint, and we will be still able to do that. And in the down, again, we are using the same, using a resistance band by tying it up at the mid level. The rectus femoris also has to be considered because that's the only muscle that's going to originate from the hip, and it's going to be a two joint muscle. And this muscle will not be a mechanically advantaged muscle, but more of a control muscle. So this is how eccentrically this is done, using both the legs and then coming down on the leg curl machine. And this patient will be on a supine lying position because that will have the hip joint into neutral. If the patient is sitting and doing, then it eliminates the function of the rectus femoris. And this is again using a resistance band. Usually it is tied just above the knee initially, or using a higher resistance, we go down. So the progression will be for this is above knee and then coming on to below knee, mid leg maybe, and foot. So surgical management, MPFL reconstruction, lateral releases. So the common exercises are very similar to what we follow on the ACL rehab. So initially the patient is on a knee brace and immobilized and is on a partial weight bearing, and gradually the patient has to reach 90 degree. And 2 weeks post-op, high sitting is allowed. And 3 weeks post-op, mostly we see if the patient is having good quadriceps function. And if the patient has got apprehension, then we allow the patient to continue one more crutch for another couple of weeks. And then if the quadriceps is less recruited, then electrical stimulation or ICE is added up to the rehab program. And we will check for any extension lag or leading to an FFD. So strength training can be progressed into the 3rd to 4th month phase. And if there is no pain and there is good muscle girth and strength, and we can progress to their rehab into sports specific training. So that will be balance based and agility and plyometrics. So coming off to cases of bilateral MPFLR. So they will have 2 braces. So this is one method how we do. So only when the patient has to walk, we will have both the braces on. And so they will have partial weight bearing and they will be able to walk with both the braces. So this is one of our MPFL bilateral patient. Now the challenge with this lady was she was also having a hereditary motor neuropathy and a bilateral foot flat. Sorry, I'm not able to run the video, but we were able to plan the exercise in such a way that the strength does not get reduced. And in her case, due to the neuropathy, the improvement in the strength was also not going as expected, but we were able to get back to her original activity, what she wanted to do. And this is another MPFL patient. The challenge was this patient left to US after 2 weeks of surgery, and his entire rehab we did only on an online session, and he was able to get back to his badminton game at 5th month. So the take-home message is the quadriceps activation is going to be a challenge. So until we get the quadriceps activation, we can work on the hip strengthening component, and selection of open kinematic and closed kinematic has to be mixed. Open kinematic is going to help more to gain the strength, whereas closed kinematic is going to be functional. A 2 weeks time frame will be to restore the range of motion and eliminate any trick movements. And then once strength is introduced, then it has to be progressively overloaded. Thank you.
Thank you, Ganesan. Regarding rehab, especially in this first time dislocators, not to start exercises too early. Because for first time dislocator, the MPFL would have tone. If the MRI, I mean, most of them think MPFL always tears. If it's subtle instability which has been happening before, it doesn't tear, it just elongates. But for a true first time dislocator, it will tear. But it has a chance of a very good chance of healing back. So during the acute phase of healing, there should not be much of effusion. So you should make sure the effusion is aspirated so that the patella falls back onto the trochlea. If you leave it with the effusion, massive effusion, it is going to, MPFL is going to heal in a stretched out position. So for MPFL to heal in a normal, you aspirate and let the knee rest. If you start early range, again, the MPFL might stretch out. So first 2 weeks rest is mandatory. Static quads can be given. Make sure there is no effusion. That's the way we can help the MPFL heal back in the normal position. So in the acute phase, not to push for exercises, let it heal. Aspirating the effusion, I think, is a key for that to heal in a good position. And regarding the rehab, I think everything is covered. Any doubts from fellows regarding the rehab part of it? Please go ahead.
Hello, sir. Good morning, sir. Prakash, professor working in Cambridge College of Obstetrics, sir.
Hello,
sir.
Welcome, sir.
Sir, good morning, sir.
Morning.
Sir, Ganesh, sir, good morning, sir.
Yeah, good morning, sir.
Sir, I have one doubt, sir. Sir, the you mentioned about rectus femoris activation. Sir, we have any specific degree of activation rectus femoris going to help the patient recovery faster? Like if you put the patient in quad stable, shall we make them to hold it for from 40 degree to 70 degree between, or any particular degree of activation is going to helpful to the patients, or otherwise we can make them to go for isometric contraction or isotonic contraction, sir? Do you have any specific degree activation going to helpful to the patient?
Sir,
Because-
for rectus femoris, the position of patient, if you put him in supine and if the legs are hanging down at around 45 degree to 50 degree, that mid range, that is a range where we know that the muscle can be at the strongest. That is the mid range. Now, the
Okay.
other thing is, at that range, we have to have a very minimum load. We cannot do maximum load, because if we put more resistance, then the other quadriceps muscles will take over.
Okay, sir. Okay.
So we put a low load, maybe around 1 kg or 2 kg. And if you do in a short arc, and if we can palpate from the ASIS to the mid of the thigh, we will be able to appreciate some amount of muscle contraction happening, which you can be very sure that it is more of the rectus femoris participating.
Thank you so much. Thank you, sir. Thank you, doctor.
Thank you. And Dr. Prashant has asked a question on more information on braces. Bracing is just for immobilizing. For medializing, there are a few braces which have straps which would bring the patella from lateral to medial. But if you have access for good taping is good. There are surgeons who do the taping by themselves. All the physiotherapists are trained with taping now. So taping wise, Ganesan, can you please, for patella instability, just few points on taping.
Sir, the method of taping, there are commonly two ways to classify. So one is the rigid one and the elastic one. So the rigid ones can give a stronger support, but again, if we have the forces of the lateral structures being more, like in the previous video, I showed a quadriceps isometrics, just literally pulling laterally. So that one, how much ever we tape and try to hold it back is not going to happen. In those patients, we need more of the elastic one, which gives a sensoric feedback that the contraction has to come from the medial side and glide towards the medial side. So that will be tailor-made for the patient for a couple of techniques. And the braces, what sir asked about the hinged braces. So again, hinged braces is going to be only giving lateral knee support and nothing to do with the patella. Open kneecap to some extent can help in the apprehension, what I've seen with patient. But the problem with the knee brace is it also suppresses the quadriceps functioning. So that becomes a little challenge for our patients.
Yeah, Prashant, we can actually advise based on, if we understand the principle of brace. If it's required for immobilization, like in an acute situation, first time dislocator, you need a long knee brace. So that's no question. But if it's a recurrent instability, you need to have a good quads. So more and more brace you add, your quads is going to get wasted. So, but as a stopgap solution, if they are getting the delayed because of various factors, you need them some kind of support, or you need a support during high demand activity, then braces might be indicated. For a gross instability, for a stopgap solution, these hinged braces with open knee will help them to some extent. But for a chronic instability, the proprioception is the thing which is working for them to help them keep it stable. So kneecap kind of a thing where it is a sleeve which is closed with the skin, rather than having a brace with straps, some kind of kneecap which gives a lot of feedback, which proprioceptive feedback will actually help them when they play certain sports, especially during high demand activities. So I will put it like that. Each brace has its own advantages depending on the patient's requirements. we can prescribe them. But bracing as a therapeutic method might not be really helpful. Hope we've answered your question, Prashant. Any other questions? Sir, your point, sir.
No, nothing to add. Thank you.
So if no more, thank you, Dr. Feroz. If no more questions, shall we end the meeting, sir?
I will say goodbye. Have a good week.
Good. Thank you, sir. Wish you the same, sir. Thank you all. We'll end the meeting. Thank you.